Well, we've been talking about neuropathy this morning. Now we're talking about nephropathy. And I'm delighted to have with me Per-Henrik Groop, who has an unusual background in that he was a nephrologist, but now seems to have acquired 2 chairs for the price of one in diabetology as well. But you're particularly interested in why people go on to develop kidney disease in a third of cases. And you started the FIN-DIAN study to find out the reason. So you chaired a session yesterday. Tell us a bit more about the insights that you presented.
Yes, Vivian. So my background is a little bit, what do you say, diverse, because I started as a diabetologist and with a special interest in the pathogens of type 2 diabetes. And in fact, my thesis was on GIP, the incretins. But when back in 1989, when I finished my PhD, I thought this is a dead end. Now it's the incretins are just on top of the agenda. So it's
that
interesting.
Means that you have to listen because this man has a crystal ball.
And because of saying this is a dead end, I went into nephrology, and that's the reason why I'm a nephrologist. But I still have a very, very large interest in the early stages of complications. So it means interested in diabetes, but also the complications. And that's the reason why I launched back in 1997 the Finnish diabetic nephropathy study, where we tried to find out why do 1/3 of people with type 1 diabetes develop kidney disease. Then somebody might ask, why are we interested in that? These 30%, they are at risk of premature mortality. They are at risk of cardiovascular disease. So these are grim consequences. They are also having a high risk of ending up on dialysis. And unfortunately, the average age of people with diabetic nephropathy, when they die, is between 45 and 50 years. So these people die young. Stroke, myocardial infarction, etc., etc. So we need to find out why do some people with type 1 diabetes carry the risk of nephropathy. That's the reason why I launched the Finnish diabetic nephropathy study, which covers the whole country, Finland, 92 centers. Now we are up to 9,000 patients out of 40,000 overall, thoroughly characterized. And there's a lot of posters, oral sessions at the meeting here, talking about and presenting data from the Finnish diabetic nephropathy study.
So tell me some of the findings from the study.
So I have a team, 45 people. We have epidemiologists, we have clinicians, we have biogeneticists, bioinformaticians, cell biologists. So we work on a broad scale. And at this meeting, we have everything from genetics. So we have done whole genome sequencing. We have clinical data on the presence of DKA, so the diabetic ketoacidosis, which is, of course, now a very important theme when we talk about potential use of SGLT2 inhibitors. And then we have a bunch of other metabolomics, the genetics of metabolites in the urine, etc., etc. So it's a broad spectrum. But this is the beauty when you have a large study like the Finnish diabetic nephropathy study. A lot of different specialties within the team, and also really, really large database. So it's a wonderful.
So are there particular genetic variants that are found predominantly in those who go on to have kidney disease?
So what we think, and the reason why we launched the Finnish diabetic nephropathy study, that must be genetic background or propensity to why some people develop. But on the other hand, what we have during the years found out is that the environmental factors are extremely instrumental, and the environmental factors that operate are hypoglycemia. So we should not neglect the effect of hyperglycemia, because these patients are exposed to the effects of hypoglycemia for a long, long time. And the higher the A1C, the more variable A1C you have, the more likely you are to develop diabetic nephropathy. Lipids, even within the normal range of triglycerides, of cholesterol, you still have slightly increased, and this is associated with the complications. We have seen that, for instance, in the presence of the metabolic syndrome, I would like metabolic syndrome within brackets because we talk about the components of the metabolic syndrome. In 40% of patients with type 1 diabetes, you see these components of metabolic syndrome, which is basically hypertension, the central obesity, triglycerides, etc., etc. They are there. And it's interesting that 40% of type 1s have components of metabolic syndrome, and the more components you have, the more likely you are to develop kidney disease. Even salt intake is something that seems to be related. Smoking, but very interesting finding is lack of intensive physical activity is a risk factor for diabetic nephropathy. So we have to sweat a little bit. It's not that you just walk around, but you have to sweat a little bit to actually have an effect. So everything goes back to the ordinary things that we talk to the patients all the time, like a balanced diet, exercise, and abstention from the excesses, not too much or not too little. So, quite a boring life. Then this is good for your health.
So your genetic destiny is not predestined, because you may have the genetic variant, but actually there's a big environmental overlay. So what does this mean for the average clinician?
Yeah, can I just go back to the genetic? We should not underestimate the important genetics, because although I said they are very instrumental, these environmental factors, we can do a lot, but still we cannot explain the whole risk. And this is, of course, important. And that's the reason why in the Finland study we are actually looking for variants that give you the propensity for development of diabetic, and they are there. And it definitely genes are operative, but it's not an easy bit to work on, because, for instance, we know how difficult it has been for the genetics of type 2 diabetes. Now, when the numbers of patients have increased in the studies, now they have quite a lot of variants. We are behind that when it comes to diabetic nephropathy. We have already discovered a few variants. So, but that work is ongoing. So we should not neglect the genes that are there. When it comes to your question around what the implications or what this means for the clinicians that take care of patients with type 1 diabetes, I would say that all what we have been talking about for years, make sure that you have optimal glycemic control, you have optimal blood pressure control, use drugs like ACE inhibitors, angiotensin receptor blockers, stop smoking, consider a lipid lowering. These are all factors that I usually talk about the 5-finger rule. And the 5-finger rule is that if you have signs of diabetic nephropathy, then the doctor should try to implement the 5-finger rule, as I said. Optimal glycemic control, A1C below 7, optimal blood pressure control, blood pressure below 140/90, or below 130 or 80 if you have 1 gram of proteinuria. Use an ACE inhibitor, angiotensin receptor blocker, stop smoking, consider a lipid lowering. This is the standard care for what the clinician should do. But first of all, what the clinician should do, they should screen for the first signs of diabetic nephropathy, which is small amounts of albumin in the urine, so microalbuminuria.
Now, you're a board member of EASD, so you have a particular interest in the program. What have been the highlights? I mean, I know you've been very busy with your own sessions, but what are the highlights for you this year?
The problem is that when you give a lot of talks yourself and you have a lot of presentations here, you don't have much time to go and see. I liked very much yesterday, of course, the EASD Novo Nordisk Foundation presentation by Professor Drucker. That was a outstanding presentation, but there are bits and pieces that I liked. And we had a wonderful session yesterday where I myself was speaking about these insights in the new insights in diabetic nephropathy that we were alluding to in the beginning of our session here. And I was talking about something very interesting. If you allow me, I can have that as one of the highlights because, as I said, I haven't been able to attend so many of the other sessions. But we talked about potential new mechanism how diabetic kidney disease develops, and that's hypoxia. And let me guide you through.
Yes.
I can explain that. Hypoxia is basically means that you don't have oxygen enough, so the oxygenation is down, and you develop hypoxia. And what I put forward yesterday was a hypothesis that maybe it's not only in diabetes. You have hypoxia, but also in hypertension and obesity. And this hypoxia that you see in these situations cause kidney disease. And the reason why I'm saying that is obesity, diabetes, and hypertension, they all go with similar factors like an increased renal blood flow and hyperfiltration. So the kidneys are working hard.
So the kidneys are working flat out.
Exactly. And then when you do that, you push the proximal tubule, the sodium handling in the proximal tubule, and 90% of the oxygen consumption in the kidneys are due to this sodium handling. And the reason why I say that this might be one of the mechanisms, because now we have wonderful drugs out there, SGLT2 inhibitors, when you block this sodium handling. And actually we have wonderful effects on the hard outcomes. So it must be some explanation for that. And then the question is, how can this be explained by hypoxia? So if you induce diabetes into experimental animals, within 3 days they have kidney hypoxia. And that stays on. So diabetes makes the kidneys hypoxic. Now, if you give a drug called dinitrophenol, which is a mitochondrial uncoupler, so without diabetes, anything...
Mitochondrial uncoupler, explain that for
I can tell you.
ordinary
So the
folks out there.
mitochondria in the cells are the power stations. And you get rid of the power station. Then you run into problems. So you use a drug that is not used to patients, but this is an experimental studies, you can use it. You cause kidney hypoxia. And then you ask, what is the phenotype? What kind of factors do you see with that? Proteinuria, inflammation, and cell damage. That is exactly what we see in diabetic kidney disease, what we see in hypertensive kidney disease, and also in the kidney disease we see in obesity. So the reason why I'm saying this, that maybe the hypoxia here is behind it because of the consequences of hypoxia in different entities. And the reason why I came back to the proximal tubule, when you have increased renal blood flow and hyperfiltration, the kidneys work flat out, as you said. You push the sodium handling, so you actually cause hypoxia because you consume so much oxygen. But this has to be proven. But this is an interesting new concept that we need to work out if it's true.
Fantastic. So you heard it here. Hypoxia may be the cause of renal nephropathy. So look forward to a presentation next year from Per-Henrik telling you about what his findings are. So thank you very much for being with us, and it's a very, very interesting theory.
Thank you, Vivian.
Thank you.
Thank you.
Much more to come.